Alright everyone, welcome to your Medicare Monday. Today we have quite a bit of things that I wanted to talk about. We have the MedPAC report that we have here. It's about a little under 300 pages of stuff. We're going to kind of go over the key points. We're also going to talk about Part D drug and the negotiation. The AMA, which is the American Medical Association, has been kind of bringing it up in their annual meeting. That also, they talk about dental, vision, and hearing benefits. We have a little bit of clarity on telehealth when it comes to Medicare, transparency in healthcare costs, and how the new kind of regulation that is coming out is going to at least shed light on why health insurance is so expensive, and also the disparity between certain healthcare insurance companies, how much they charge for things, how much their competition charges for things, and how much an uninsured patient would have to pay. We'll talk about medical debt, and then I'll talk a little bit about inflation, as I will have the retirement resources update that would have been posted last Friday available. And that I'm going to talk a little bit about inflation and just what you can do in times of stock market downturns. We have this acronym in finance called, or it's not in finance, it's actually a political acronym called TINA, which means there is no alternative, when in fact in the financial markets there's a ton of alternatives. So we'll go into some things like that in the retirement resources retirement resources video, not podcast. I have one of those, but it has nothing to do with Medicare or finance. But anyway, let's get right into it. So in the Medicare and the Healthcare Delivery System report, they go into a lot of things about how much things cost, how much, how they're dealing with certain costs, and how cost is being more and more, I guess, uncontrollable. The main things is this MedPage article today talks about is Part B drugs being really expensive, and how it is really Medicare is paying full price, probably an overly inflated price, for all the drugs that go through Part B and in Part D, as we'll go into research a little more of that. In the commission, one of the things that the MedPAC article really harped on was alternative payment methods for Medicare. So this has really nothing to do with how Medicare beneficiaries are going to be affected. Hopefully it has a lot more to do on the back end with physicians. So currently the fee-for-service Medicare system, that's, you can think of it pretty much as if the doctor sees you, the doctor's office will bill Medicare for whatever service you did and get a reimbursement based on their demographic area. What Medicare wants to do is to have more of a kind of like an HMO system, where the payment model will be a different type of payment model, where perhaps instead of having the doctor bill every time you come to see them, the doctor simply gets a flat rate for having you on the panel, and Medicare will have a kind of a centralized data system where if you are assigned to this physician, that's the physician you see, kind of like having a primary care doctor at one of the larger hospital systems. And that way it'll keep costs down for Medicare, but it also puts some risk on the physicians, as now the physician will have a flat rate, let's call it $100 a month to see you. If you see him or her 2, 3, 4 times, then it's not really beneficial for the physician. So what MedPAC is kind of saying is, we might be, or Medicare might look into kind of pushing that payment model versus the current payment model, which is unsustainable and potentially wasteful. They also talk a little bit about Medicare Advantage, and that's for a different video, but last year anyway, Medicare Advantage, this is their overhead costs. We got 13, 17%, while Medicare's overhead cost is only 2%. So what a lot of, I guess you could call it, proponents of Medicare Advantage are saying is that Medicare Advantage will help cut down costs on care delivery and on the Medicare system, when in fact, if you look at this, it's very unlikely, that they can, seeing their overhead costs are really expensive in comparison to the regular original Medicare program. So a lot of the care might not be actually delivered to the members simply because it's been transitioned to pay for things like this, things like claims processing, prior approvals, marketing, CEO salaries, and profits. So something to kind of think about. It's kind of going on anyway. So Medicare drug pricing. The AMA, which is the American Medical Association, they kind of talk about how they are in favor of setting, I guess, limits. And their main concern, though, well, the main concern of the opponents and those for this kind of health drug pricing negotiation is where do we start from? Where is our index of all these prices, and how much is the fair price, right? Currently, the price that Medicare pays is whatever the pharmaceutical company decides the drug is going to be on the market for, right? There's no negotiation. If it's kind of like if you went to McDonald's and the Big Mac was $100 and the hamburger was $5, no one would ever buy a Big Mac. Unfortunately, in this scenario, the Big Mac is insulin, and tons of people need insulin, right? So it's kind of an unfair situation where people need life-saving chronic maintenance medication that is overpriced. Overpriced is kind of subjective relatively, right? I mean, who knows, it may cost $100 to create, but Medicare is saying that, hey, we need to kind of work on it. And honestly, I don't believe what I just said. It's kind of poking fun at it, but anyway, that's kind of where this conversation is going. Along with this article, they talk a little bit about dental, vision, and hearing. And dental, vision, and hearing is something that is hard to understand. So in the 80s, Medicare was just kind of getting its legs under it, let's call it. Not all the doctors wanted to accept Medicare, but Medicare made it so that you kind of had to, or at least a good amount of people have to accept Medicare. And by doing so, they really hurt the reimbursement model for physicians. So physicians had to take on a whole bunch more clients in order to service, or in order to survive financially. Dentists don't want that to happen either. So dentists are fighting tooth and nail to not be included in Medicare, simply because once that happens, let's say they're cleaning, right? Routine cleaning. It's $100, let's just call it. And now, because they accept Medicare, routine cleaning for Medicare patients is $40. This is public information. As an insurance company, a health insurance company whose sole purpose is to save their members money, they're going to look at that cleaning that Medicare gets, Medicare beneficiaries get, and say, hey, you're charging Medicare beneficiaries only $40, that you're charging my clients $120. That is unfair. I want better pricing. And then the dentist now, in order to keep the contractual relationship with the insurance and being a provider who accepts the insurance, they are going to have to negotiate down their current price of the cleaning. And you might say, well, $100, that's a lot of money. I mean, it is. But dental offices have staff, they have medical malpractice insurance they need to have, they have the bill of the actual office. So they're looking at it like, hey, this is the physicians, like, we know the physicians are overworked. I mean, my wife, when she was working at Straub, some of the doctors she worked with would see 50, 60, 70 patients in a day. And on top of seeing the patients, all these doctors would have to chart, they'd have to call, they'd have to look at the if tests were coming in, all of that stuff they have to do. And dentists don't want to do that. They're happy, seeing whatever 20 patients a day, and enjoying their life. They don't want to be in a place where the primary care doctors are, where they're just working 80 hours a day just to kind of keep just to keep up with their workload. So that's the dental vision hearing argument. Also for hearing, many people who are provided hearing aids don't use them. And with hearing aids being in the $1,000 ranges, giving someone $1,000 item for them to simply lose it or not use it, Medicare is thinking or looking at the cost benefits of this program. Yeah, so there's a lot going on. Telehealth. So as you know, with the pandemic in 2020 and all the lockdowns, all the no leaving your house kind of rules, Medicare upgraded their telehealth service delivery. So now basically everything that is available, that you could think of available through just talking to your physician, that stuff is all available now through telehealth. And it doesn't have to be with the video, it could just be over with voice. And it also kind of made it a standard Medicare Part B service. So Medicare Part B, for those of you who are new to Medicare or need a refresher, Medicare Part B has that initial annual deductible of $233 in 2022, and then your 20% co-insurance if you don't have a Medicare supplement plan. For those of you on Medicare Advantage, it's going to depend on your plan. For most folks who have a Medicare supplement plan, that would be a zero copay after you met your deductible. So it's a good deal, and Medicare has through this been able to reach a lot more folks. I'll tell you from first-hand experience, in where I live in Texas, there is a lot of problems. It's hot, seniors might not be able to make it out of their house because it's too hot. They don't want to go to the doctor's office, or it's snowing, or the weather's really bad. They just want to stay home. This allows them to switch the appointment on the fly pretty much to have it at home versus going to the office. Instead of delaying and postponing it, they can actually change it to a video visit or a telephone visit. And to kind of piggyback on that, if someone cancels, then the physician can quickly book a video visit for someone who's waiting for a visit, so that care can be kind of delivered more, I guess, quickly. And to me anyway, that just speaks volumes to kind of the progress finally that Medicare is taking. The next thing we talk about is healthcare transparency. So there's in 2022, hospitals, as you can read here, began publishing their negotiated rate schedules online, and they kind of interestingly found that there's so much disparity between how much people are charged, how much insurance companies are charged, how much insurance companies are charging, and how much hospitals are charging. A good example is an MRI of the brain, which I've had before, under UHC, is 4 times the amount a cash paying patient would be charged. So if you have a healthcare plan that is this United Healthcare plan that has a 25% copay for an MRI, you're paying exactly the same price as someone who does not even have insurance would pay. Doesn't make sense, right? Also, the same hospital just receives 2.5 times the price from Blue Cross patients. If you're a Blue Cross Blue Shield patient, your copay, well, let's not talk about your copay, the price that the hospital charges that insurance and that insurance company's member is 2.5 times the cash paying versus the 4 times on the United Healthcare plan. So it's very much all over the place. Doesn't make sense why something could cost more on one insurance plan and on another one. In addition, the pharmacy. So I believe it was last week Tuesday, I posted a video on how the price disparity between all different pharmacies and insurance and coupon programs can change, and you can get in medications it's like, $100 on insurance for like $15 without insurance, and this doesn't make sense, right? This is exactly the same kind of thing, except in a much larger capacity that affects many people, because for some strange reason hospital and going to hospital, that seems more, I guess, emotionally charged than speaking of medication from the pharmacy. But all in all, it's just saying the entire system right now is under review, under scrutiny. So be aware, I post these things hopefully every Monday, so it'll be out in there. And the last kind of main article is there's 100 million people in America that have medical debt. That's a staggering amount of people, because we're in a country that has health insurance, and granted it's not the best health insurance, but we have the best health, we would think anyway, one of the best healthcare delivery systems. I was being sarcastic. But anyhow, there's this lady here who, her and her husband were sued by the New York hospital for $10,000. Someone from Arizona who, like me, sells health insurance, couldn't get an appointment with a doctor because he had an outstanding balance. And I'll tell you, out here in Texas, my wife could not make her appointment unless she prepaid for it. I don't know why, because she's an employee of the healthcare system that we are part of, with the insurance plan that we are part of, but they told her that she has to pay before she goes. Right? Crazy. Allison Ward, their husband, they loaded up all their credit cards, borrowed from their relatives, delayed paying off their student loans because they had to have a delivery, or they had to deliver their children premature. That is crazy. So medical debt is affecting everyone, and a lot of people say that they just will never pay it back. They'll just keep paying the minimum or whatever, because they just don't have $10,000 lying around to dump into this medical debt that they have incurred. And our system is not set up to deal with any of this, simply because, right, it's more of a, it's not my fault, it's not my responsibility, it's the patient's responsibility. And remember that, because on Medicare, a lot of times that is how it's going to be. It's going to be the patient's responsibility to kind of maneuver the available, albeit insufficient systems, but they're there for certain populations, and it has a lot to do with financial, not making a lot of money. If you make a lot of money, then you have to pay a lot of of healthcare services. So just be in mind, be aware of the things that could happen. Now, there is no other alternative. This is interesting, because I hear this a lot in finance, because when I talk about the stock market, for those of you who don't know, I used to have a financial advisory practice until I went straight into or just into like Medicare and insurance and annuities, because I feel like that's a far more transparent and simpler, straightforward kind of a tool, and also it's very necessary. And as a financial planner, I kind of demonize a lot of it, and when further looking into it, it just makes more sense, especially now we can see that the market is tanking. But there is no alternative is from Margaret Thatcher, and it just says that the reason why we have any kind of system is that it is the best system. Simply that's it. The medical system we have right now is the best system because there is no alternative. The financial system we have right now is the best because there is no alternative. It as you can tell, it is faulty reasoning, simply because if we believe that the only reason why anything is here right now is because it's the best, then there'd be no evolution, there'd be no change. And what I'm kind of talking about is in the term of the stock market is there are alternatives like annuities. There's things like putting money into inflationary bonds. All these things that you can do that don't rely on you buying more into the stock market or selling, your all of your securities, or what have you, that the financial media would tell you, because I listen to financial media with a grain of salt almost every day. I look at charts, so I trade primarily based on charts, technicals, and news, primarily because that's when big moves happen. And if you believe in kind of like the market makers and the invisible hands that wrap around the market and make things happen, you kind of realize that there are a lot of discrepancies in the market. But I won't go into too much of that. Actually, I probably won't go into any of that because I might get found and they might try and take me down, so to speak. But for inflationary kind of talks, inflation is hurting us right now in three major areas. So that's groceries, they're almost 12% based on the core CPI report. The fuel prices, gasoline, oil prices, natural gas, very expensive, up 50%. And utilities, so electricity, all things that are energy related. And that's a big chunk of budgets for people who are retired. So what can you do? Well, for right now, can't do very much. We have to kind of contract a little bit, and that is exactly what the Fed, people who are making all this like high interest rates, crashing the stock market. Well, I don't think they're crashing the stock market, but I think that we have to kind of be knowledgeable of what we need and versus what we want. And when the market gets back, when the economy gets back, then we can kind of start branching out again. But remember to keep the things that you value up front. So don't cut out your health insurance to buy a new TV, even if the new TV is 20% off, because TVs and such have gone down actually in inflation. So don't buy those things. Let those things falter and be oversupplied so that we can get them next Christmas for like half off, right? Let those things happen. That's fine. The companies are meant to be kind of fixing their own problems, and they can deal with supply side chain issues and economics their own way. The demand side part is really the only part that we can focus on. And buy the things that you need, don't buy the things you don't need, and let this kind of, I don't want to say it, but I will, this kind of recessionary bear market points to kind of just falter out. Well, that's it for today. Hope you guys learned anything. Have a great rest of the week. Stay safe, stay healthy. Remember, Medicare is there for you to use it, but you also have the most important thing that you can, which is your own well-being, and that is the most important thing. You guys have a great week again, and I'll see you later.